Hey, Dr. Cabullo, good morning.
Hello, good morning, Dr. Bennett. How are you?
How you doing?
Yeah, I'm great. And your side?
Okay. How's your Sunday?
Yeah.
Do you have the whole day off or just part of the day?
Sorry?
Do you have the whole day off?
Yes.
Oh, good, good. Okay,
Yeah.
I'll be back. Okay,
It's okay. I'll be back also.
okay.
Thank you.
I'm just doing some promotion now
It's
for
okay.
my
What time is
smart.
it starting?
For my, I'm doing some promotion on my smartphone.
Oh, that's great.
Yeah, what I do is I go to Facebook right now, and I go to
Mhm.
my account with the post, and then I spread that around.
Mhm.
Let's see here.
It's okay. What time are we starting today?
Well, we're starting in about 10 minutes.
In 10 minutes. It's okay. I'll be
Okay,
back.
hold on. Okay. Hey, Abraham.
Hello, Dr. John.
How are you doing today?
Oh, good. Thank you. How are you?
Great. Great. Things are really going well. Hope we get some people here today.
Two presentations today, right?
Yeah. Yeah. Well, you know, one of the guys is the head of Kazakhstan.
Mm-hmm.
It's neurosurgery. We're trying to get things going. Do you ever? Of course, it's famous because of you know who, more than anybody. And I try to resist asking people that that are from Kazakhstan, but all these places can benefit by this type of learning online. Do you see how big Kazakhstan is?
Yeah, of course.
It's
Yeah,
a huge place.
Yeah.
It's huge. And they could use online education in a place like that.
Right.
The places are so far away, man. So how's your school going?
Thank you. It's all right. Exams are approaching.
Oh, you're in exam time now?
Yep. Right.
Okay. I'm trying to think what after. Oh, January's exam time. So your semester's ended.
Well, it's in February here in Germany. Yeah.
Now, German, it's pretty tough, right, in Germany?
Oh, I wouldn't say it's easy.
Yeah. Yeah. What year are you?
Fourth.
Okay, and there are how many years of medical school?
Well, 6 in total.
Oh, wow. Then you apply for internship.
No, 5, and then the 6th year is internship.
Oh, okay. Okay. Yeah, and okay, so that's not too bad.
Well, I'm doing 7 in total because I'm working on a PhD.
Oh, okay. You got a combination platform.
Exactly.
Oh,
right.
Okay.
It takes me.
You know Dr. Cabullo, right?
Yeah, of course, I know Dr. Cabullo.
Yep.
Yes, Dr. Ibrahim, how are you?
Thank you. Thank you. How are you?
We interrupted your baseball game. Yeah. Yeah, we got 2 lectures today, Dr. Cabullo.
Oh, thank you so much.
Good. Oh, good. Khalif is here. Both of you guys know Khalif.
Yeah, of course.
Good. Khalif is here. I can see Ipa's on his WhatsApp.
Hola, John.
Hey, hola, ¿cómo está? Hey, how you doing, Khalif?
Muy bien.
Welcome.
Hello, Ibrahim. How are you, sir?
Hey, Khalif. Thank you. How are you? How is Valencia?
Khalif, how are you?
Valencia.
Hey, hola, ¿cómo está? Hey, how you doing, Khalif?
I'm good, man. I'm good. It's raining here. It's cold, man.
Really?
Yeah.
Dr. Khalif, do you speak French?
No. It's not French, my friend. It's Spanish.
Oh,
Española.
okay. That's Spanish. That's where you say, ¿Cómo está? Dr. Khalif, do you speak French?
No. It's not French, my friend. It's Spanish.
That's Spanish. There's an echo. I think someone is on Facebook and on Zoom.
Let me get my earphones.
It's okay. There's an echo. I think someone is on Zoom.
Let me get my earphones.
It's okay. There's an echo. I think someone is
Oh. I see Ipe in the chat room. You guys go to that WhatsApp chat room. I think Abraham does.
Mm-hmm.
Ipe's
Yeah, I also go there.
pretty active WhatsApp group. You've been following, right, Abraham?
Yeah, of course.
That's a good. I don't see too many WhatsApp groups where there's so much interaction as that one. Okay, I knows. You've been following, right, Abraham?
Yeah, of course.
That's a good. Someone's got their Facebook open. It could be me. Maybe check. I'm getting off all my windows. Sometimes I get confused. So yeah, I'm going to Mexico next week.
Oh, great.
To meet with a possible investor.
Oh,
It's for the Spanish part of not neurosurgery, of everything.
I mean, that's awesome, man.
No, not just neurosurgery, all specialties using the same template.
Congratulations.
Yeah,
This is going places.
Yeah, well, it looks encouraging. It looks encouraging.
There's a delay in the
audio. It looks like it's. Did I freeze? No. Let me check with Ape again. Let me try Ape again. Khalif, I'd like to hook up with those people in the lab. Oh, you can't do anything. Yeah. You're going to be home in a couple of months?
yeah, I'll be back in Nairobi in March. And
wow, okay. You're away for a while. You're going to be in Spain for another with Dr. Gonzalez, right? Okay, let me check with it. Khalif, I'd like to hook up with those people in the lab. Oh, you can't do it. You're going to be home in a couple of months? Yeah, I can hear someone's Facebook. Is that me? Maybe it's me.
Well, we are all muted. It has to be you.
I've done that before. I'll say someone, I can't hear you. I can't hear you. But I have my volume off, so I can't hear them, obviously. And then finally, I'll find the volume button, turn it on, it'll be fine. But then I won't say anything, though. Where is Ape?
No, Khalif, I can't hear you. But you can hear me, right?
Can you hear me now?
Yeah,
Yes.
yes.
Oh, okay.
Oh, so you brought your headphones. I
Yeah, I
use,
use the headphones. The problem
Wait,
is I
you
didn't
know,
connect.
it's not connected. Your headphones not, because I can't hear.
Yeah,
I can't hear it as good as it should be.
yeah.
Can you
I'm
move the
trying
mic
to
move the mic
connect.
away from your mouth?
Can you hear me now?
That's better. That's better.
Yep. All right. That's
Yeah,
it. All right.
like you can tell a difference, right?
Yep. Big
Yeah,
difference.
I can tell it's a big difference, and
Yeah.
I'm going to try to get Ipe to use it, but some people just don't like wearing the head thing. You've seen the
They have good,
lapel.
nice hairs like Ibrahim there.
Well, you know
Those guys are bald. Nothing
yeah,
to.
yeah. You know the TV people, they just use those little lapel. They pin something on there.
Yeah, and that behind the hairline.
Yeah, and you can hardly see it.
Yep.
And they're pros. That's their business.
Ibrahim, you're preparing for exams, you said?
Yes, right.
It's a neurosurgery exam or it's a general exam?
Well, it's on a bunch of different specialties. I mean,
Okay.
I'm a fourth year student, right?
Okay.
So I have to cover cardiology and gastro and
neuro.
well, yes, neuro as well.
Okay. I got some nice questions for neurosurgery. When you're interested, you let me know.
All right, yeah.
I'm preparing for
amazing.
exams too in next year.
Okay. What is that? Board exams or?
It's a board exam. It's a collegiate exam.
Okay.
Yeah. It's by external examiners who come and examine us.
All right.
It's quite a tough one.
Okay.
Yeah.
When do you have to study for that?
Oh man, I'm starting already. I'm scared.
Oh yes. Okay. All right.
Yeah, I've got one year and something.
Okay.
No, I've got exactly 1 year now. No, 1 year and a half. 18 months I have.
All right. Damn.
It's
okay.
September next year.
That must be a tough one then.
It's a tough one. I need to ace it.
Okay.
Yeah. And I also want to sit for the FRCS around that time, so I need to be prepared.
Okay.
And the FRCS is really tough. No jokes.
But if you do FRCS, is that like, are you aiming for England or?
Yeah, the FRCS is usually by England, but it's a good exam to have.
Yeah. Okay.
And yeah, by the time I finish my exam, then I'll be eligible to apply for that exam. Yeah, so I'm planning to do it around at the same time.
Okay.
So it's killing two birds with one stone.
Yeah. Right.
Yeah. So if I do my COSEXA exam, my college is called COSEXA. Then maybe within 3 months, I sit for the FRCSSN.
All right.
Yeah.
Well,
You'll
are
be
you-
doing the European exam.
Mm-hmm.
Yeah. After you join Neuro.
All right.
You're going to New York, right?
Yeah, man, but I don't know. The visa is becoming a little bit of an issue, so I have to go back to Nairobi and apply one more time. They told me I applied the normal tourist visa, so they want me to apply for a different type of visa.
Oh, so it'll be delayed going to Cornell?
No. I will go to Cornell.
When are you going there?
Planning in April, so I'll be in Boston for the AANS. You're going to be there?
Oh, you're going to be in
nice.
Boston?
Yeah.
Oh, wow. What are you going there?
I'll be there from April 24th to 30th.
Wow. You're
Yeah.
all over the place, man.
I'll be over there. I hope to plan and visit you in Miami, at least to come to the studio.
Yeah. When
And
you
all the
gonna? So
sessions
when
from there.
exactly you coming to Boston? Boston's the first place you're coming.
No, I'm going to New York first.
What date?
I hope to be there by April 1st.
April.
Yeah.
Okay.
Yeah. Hopefully.
Yeah, I go up there now and then to my family's from Boston, around there.
Oh, so you're going to Boston for sure.
Yeah, so I go up there
We can
not
do
pretty
that.
often, a couple times a year.
Oh, okay.
Okay, here's Ipes coming in. Yeah, it's nice. This time of year it gets cold up there.
Yeah. In
If you think
Spain,
it's cold there in Spain, you wait till you get to Boston.
Oh, Boston is going to be cold, yeah? No,
Oh,
but
yeah.
in April it's
Oh,
not going
yeah.
to be cold.
Oh yeah, colder than Spain.
Oh, man.
Yeah, colder than Spain.
But I lived in Russia for 6 years, so I'll
Oh
survive.
Jesus! Wow. So
Yeah.
you know what
Nothing,
cold
man.
is.
I know what cold is. I know what -30 is.
Oh man.
Yeah.
I lived in Canada for a while. I mean that's like
That's
Russia.
extreme cold.
It's like
Yeah.
Russia.
Yeah.
You were in Moscow?
I was in a place called Saratov, south of Moscow.
Oh, south of Moscow. Okay.
Yeah.
Yeah.
It was really cold.
Majorly cold.
Yeah.
Have to plug the cars in at night.
Yeah, you can
So-
drive the
so-
cars until that vehicle
Everything.
clears
Well,
the
it freeze.
snow
The
and
engine will
stuff.
freeze unless
Yeah.
you plug it in.
Yeah. They use an antifreeze coolant.
Oh, really?
Yeah. Otherwise the car won't start.
Yeah.
Yeah.
Yeah, it's funny.
It's a crazy place.
When I first lived
But
there,
I loved it when I was there. I loved it. You know, in Africa, you never see the seasons like summer, winter, autumn, spring. We don't have those things.
Oh, in
It's
Kenya, you
always in
don't.
summer. It's always
It's-
green and raining and hot and humid
Oh, all year round.
12 months a year. In
Well, you're on
Russia,
the
it's
equator.
really
That's the
different.
equator, right?
You really
Okay.
experience the 4 seasons of the year. That was the highlight.
Well, Kenya's on the equator, right? Pretty close to it. So yeah, Ip says he knows about it. So So we have the Jordan Grand Round starting again, but that's stopped for a couple of weeks. We have that Wednesday.
What is going to happen Wednesday, John?
Yeah, the Jordan Grand Rounds, Dr.
Oh, yeah.
Sabea.
Yeah.
Going to
Wednesday
restart
night.
it. He took a couple of weeks off.
Oh, okay.
But yeah, I hope to have a lot of countries doing Grand Rounds.
Yeah.
The gentleman that is speaking second, Chinitz,
Yeah.
head of Kazakhstan. I guess Ip wants to start a Central Asia type of community
Okay.
to have some kind of regular hangout to get them in the fold.
Yeah. IP is doing a lot of good work.
What's that?
he's doing a lot of good work in terms of education, neurosurgery education. He's very passionate.
Yeah.
Yeah.
Well,
And very radical.
I'm trying to get some connections in. Tanzania. I'm working with the tech there because
they work with Cornell.
We have to really get a good. Cornell's been doing. I didn't realize they've been doing something for years with.
Yeah, for 12 years now. Roger Hartol is
Tanzania,
been doing,
and Dr. The gentleman from Cornell, Hartl.
Yeah.
He's been going there for years.
For 12 years now.
He travels a lot, man. He goes to lots of conferences.
Yeah.
Okay. Oh, here's I. Okay, now the party starts. Ipe, can you hear me? It looks like you're on two connections there. One of them you're muted. Let me unmute you there. Can you hear me, Ipe, now?
Yeah, can you hear me?
Yeah, I can hear you.
Okay, so we are on. So
okay, your screen's not, your video's not on, Ipe.
Yeah, can you 1 second, John, 1 second.
Okay.
John, today, John, can you close off this one? The other one, the other Ipecherian one?
Okay, you want to, okay, I can pinpoint that and keep that screen on. You want to do that? I see if, oh, there you go. There you go. Okay.
Yeah, can you see me?
Yep.
Okay. So today, Ahmed is going to do the, 1 second, Ahmed. Yeah, it will come right now. So it is complete. It's not completed. It's just copying. Today, Mohammed will do the Super Sunday. He's going to show a phylum terminal epidermoid tumor. So even today we did a very interesting spine case, an anteriorly placed tumor, which we took out with a very minimal hemilaminectomy, and after the resection was done, we used flexible endoscope to see the code. Otherwise, we just opened using navigation. We just O-arm and navigation. We opened exactly over the tumor and got out this tumor and took out this tumor completely. and we reconstructed the dura, and the cord was completely intact with the pia, everything intact. So I'm just getting on to a little bit of minimally invasive spine surgery.
Oh, okay.
Not that I would love to do it, but then tumors are something that I like. So we did a very, very small, maybe a 1 centimeter, 2 centimeter, and probably by a 0.5 centimeter to 2 centimeter minimal laminectomy, hemilaminectomy, completely over to one side. And then we went ahead and took out this tumor. It was a completely anteriorly placed lesion. So here we will be showing you something that we did some time back, maybe last week or something. We have a epidermoid.
Do you want to start, Ibe, so you can get this all on tape so people can see it?
Yeah, so 1 second. So you can take the USB now, and then we are starting right now.
You want me to start right now, and then you can go where you want to go?
Sure. Mohammed is starting now, and I'm going to put it in, Mohammed.
Yeah, let me just introduce you, Ibe, and just go where you want to go. Okay.
Yes.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have another Neurosurgical Super Sunday with some panelists. Let's first go around and meet the panelists before we turn it over to Ibe. Hello, Abraham.
Hello, Dr. John. Hello, Dr. Ibe. Hello, everyone. I'm Ibrahim from Berlin, a medical and PhD student.
Yeah, welcome. Hi, Dr. Kabulo.
Hello, Dr. John. My name is Kabulo, final year neurosurgeon resident at the University of Zimbabwe.
A frequent visitor here. Okay, Deepak Bengali. Can you hear me okay? Deepak may have stepped away. Khalif, how you doing, Khalif, today?
Hello, I'm Khalif from Kenya, currently in Spain. I'm a neurosurgery fellow in the College of Surgeons of East Central and South Africa. Greetings from Valencia, Dr. Ibe.
Hey, welcome. Hello. Very good. Okay, Ibe, welcome, and it's all yours.
So, John, I'm going to share the video right now. So, can you see the share part?
Yes, we're screen sharing, yeah.
Okay, so you can see now, right?
Yes, you can see the desktop.
Okay.
Yes, we can see it. Yep, we can see it.
Hello, John. Hello, everybody.
Could you please introduce yourself?
Me, Mohammed. I'm Dr. Ibe Fellow. I'm an Egyptian neurosurgeon.
Welcome.
Welcome. Okay. Today we would like to present some beautiful cases of rare tumors in Coda equina region. This tumor is dermoid or epidermoid cyst. As everybody knows that most common tumors in conus or region of Coda equina are myxopapillary ependymoma. However, some cases maybe have rare tumors such as epidermoid or dermoid cyst. The most interesting thing in that patient is that he still have a tuft of hair over his lower back. So it was a clue of diagnosis that it may have something congenital. Everybody knows that that dermoid or epidermoid tumors are inclusion cysts that formed due to the inclusion of epidermis or dermis, included keratin, and goes all the way down with neural tissue during early embryogenesis and fetal life. We would like to present this case right now. This microscopic view of dura after laminoplasty. We took lamina, not laminectomy, but laminoplasty. We'll put lamina back. think this is not the video. Dural opening. This is not the video. Dr. Aib. This is not the video.
Huh?
Not the video.
Okay, the video is not playing, I guess. Yeah.
Yes, there's some technical problems, but you wait for a second, please.
Okay.
What happened?
This is not the video.
Not the video?
Yeah. This is only opening of.
Okay, no problem. So no, it's okay. It's all right.
So it's not keeping playing.
Unexpected failure.
Yeah, I don't know why that's stopping.
Better to do that in videos rather than in surgery. Hello.
Does
Yes.
does the video play on your computer, I wonder? Alone.
I think there is some problem.
Does the video play outside the Zoom platform? If you just click on it on the desktop, does it play?
Yeah. I mean, it was playing very well. What you can do is,
Because if you just play it on the desktop and capture it.
you know what, John, I'm going to come into Neurosurgical TV using another. Hello. Yeah. What I'm going to do is that there's another. Let me just close it off.
You can just send it to me, Ipe, and I'll play it and capture it. If you send the file to me, if it's probably not a big file.
Yeah, I'm trying to do something like this.
Okay.
That's not the key, huh? That's not the key, huh? John, I'm trying to get this working now.
Okay. Yeah, it's working now. It seems to be working. Oh, I see.
No, yeah,
So it keeps flipping off, huh?
No, yeah, I think there's a technical problem, so I am.
Yeah, just send us a file.
Yeah, maybe I'm trying to do that. It's 0.99 GB, you see, that is much smaller.
Try opening it a different player.
I'm doing that, John.
Okay.
You know what? During this time, see if it is working, Ahmed. Yeah, it's working here. It's not working here as well. John?
Yes.
So we have a problem. So what I'm going to do is I'm going to slightly improvise and I'm going to show you another video.
Okay.
Okay. Khalid Abdifati Abdullahi Jimo, what kind of videos do you guys want? I mean, do you want some basilar or do you want some ACOM with introp rupture?
Good afternoon or morning, wherever you are.
The videos, I just finished the tumor, so the videos are not yet available. I just finished that tumor, so I mean, I just finished it maybe a couple of hours back. So that video is not yet available. It'll be available to only all by tomorrow. So if Chingiz is not here, then what I can do is I can show you maybe a basilar tip or something like that. A basilar tip is okay?
That's okay. It's all right.
Right. So
you don't want to try sending me the file, like?
No, even that file is not working, John. I don't know what happened.
Oh, okay.
Because me and Edmundo had sat and finished that, but then oh, it's not that tumor. I got it now.
Oh, okay.
Good.
Eureka.
Okay. I got it. Eureka. Okay, you copy that. Yeah, I got that.
Okay.
Fantastic. Yeah, take a USB, copy that into. Okay, till that time, let me show you a basilar. Can you see, guys?
Yes. Yeah, it's not playing yet. Oh,
Yeah,
there we go. There we go. It's moving.
Can you see the basilar aneurysm?
Yep.
Okay, so we are going to see this. So the usual mini OZ approach that I usually do. You have enough time, so copy it and then we can show it here. Okay. So I'm doing the clinoidectomy. And here I really don't have to worry about the clinoidectomy because there is no aneurysm lurking under these clinoids. So I can do fast clinoidectomy here. And this clinoidectomy as well as the dural opening is only for the fact that to do an axial unlocking. So the brain temporal lobe is taken away extradurally from the cavernous sinus. That is why I'm doing this for. So I'm doing a basilar, this basilar aneurysm. I want axial unlocking so that I have got very good approach to the interpedunclar fossa. Now you can see that is the optic nerve.
Okay.
And
you're now intradural.
Yes, I'm intradural now. That is a carotid. That is the third nerve. Can you see the arrow? That's the third nerve.
Yeah.
That's carotid. That is PCOM.
Okay.
That is the opticocarotid window which I'm widening. Can you see that? This is optic, this is carotid, and the opticocarotid window I'm widening. I'm using a diamond knife to widen the proximal sylvian. You see, all these windows are very, very important. So when you're doing a basilar, obviously it seems like you don't have any space at all, but you start opening all these windows, then you slowly will start getting more and more and more space. So if you panic and if you try to put in a lot of pressure, and then you will have a lot of problems. So here now I'm opening the membrane of Lilliquist. You can see the basilar complex there. So in the basilar complex, I have to identify the third nerve. So it's full of blood. You see, it's a ruptured aneurysm.
Yeah.
So it's full of blood. So we are going slowly, opening the membrane of Lilliquist, and then we will go find out the contralateral third nerve. Okay, that is what we are looking for.
Contralateral third nerve. Okay.
Contralateral third nerve. So the contralateral third nerve is always between the P1 and the superior cerebellar. So see, I'm cutting the membrane of Lilliquist. Going there, and finding out, trying to find out. That is the contralateral. Can you see the white structure there?
Yep.
Yeah. So look, can you see the white structure there?
Sure.
1 second. Let me show you once more. That's the most important part. Okay. You will see that white structure.
There. Yes.
That white structure. So
that's
that
the contralateral third nerve.
That's a contralateral third nerve. So that is the basilar.
Okay.
This is P1. Underneath the contralateral third nerve is your superior cerebellar. This is your P1. This is your other P1, and that is the aneurysm. So that contralateral P1 is your guide. Okay. So that is, so the contralateral P1 is exposed. Above that is P1. So that is P1. That is P1. So that is the basilar tip. I mean, so P1, and that's aneurysm. Okay, it's a posteriorly pointing aneurysm. I am keeping a patty and gently dissecting the aneurysm down.
That white structure there is the ipsilateral third nerve.
That is aneurysm.
Okay. Okay, just where the retractor or the dissector was. Lateral.
Yes.
Yeah.
Yes, I am dissecting between the aneurysm and the P1. This is the P1.
Okay. Yeah.
This is the aneurysm. Okay.
Yep.
It's not a very pleasant scenario. I don't even have proximal control. No proximal control at all here.
Of course, no. But Prof, I wanted to ask, do you tell the anesthetist to bring down the map, give more oxygen, reduce the carbon dioxide? Any tricks at this point?
The only trick is to, hold your breath and tell the anesthetist, if it ruptures, be ready for the cardiac arrest. Okay.
Okay.
If you have cardiac arrest, this patient will die on the table. So we need to have cardiac arrest. Sometimes we need to have cardiac arrest. Also, for the aneurysm to soften, sometimes I use cardiac arrest. 20 seconds cardiac arrest using adenosine. Okay. So the heart stops and then I clip. Okay. So I am taking off all the vessels there. You got that USB here? Get the USB here, please. Yeah, so do you see that I have space now between the P1 and the
aneurysm?
Aneurysm?
Yeah. Yep.
Can you open the door, please? Yeah, and now I am putting the clip there. First attempt, I could not put the clip on. And second attempt, between P1 and the aneurysm, going in, and finally, gently out, clipped. Okay?
Yeah.
You guys liked it as an interval between the phylum.
I think it's more, what do I call it? Nerve-wracking procedure compared to the spinal tumor.
Yeah, okay. So I'm going to hand it over to I'm going to hand it over to Mohammed for the phylum terminate tumor. So I will close this now. So I'm sure you enjoyed the time that we were waiting for the phylum terminate, because the basilar aneurysm is not clipped in many parts of the world now. So probably in United States and Europe, very few people would clip a basilar. But in this part of the world, we have no other options. And also, we are good in clipping. So, so we can clip the basilar without much issues. So that is one basilar. Now, Ahmed, you have put the...
Yes, I put it.
Yeah. So so we start now with Ahmed's tumor. Okay, now I think we have the tumor here. Okay, right. Ahmed, carry on, please.
9 cases.
Okay, there's Naru. Hello, Naru.
Hello, John.
Opening the dura. Some
I
commentary, please.
remember this case because I operate this same cases with my professor in last October.
Okay.
It's very nice cases.
Okay, everybody's ready?
Yep.
Yes.
Okay. Today we will present a case of spinal dermoid cyst. This was a male patient about 20 years old, presented with conus symptoms. Patient have urine and stool incontinence, but he was intact regarding motor power of his lower limbs. Also, by examination, we find a tuft of hair over the lower aspect of his back. So this tuft of hair was a good clue that this patient may have a congenital cyst in the spine. And the most common congenital cysts of the spine are dermoid and epidermoid tumors. After patient has been anesthetized, general anesthesia in prone position and midline skin incision over between D11 to L3 and laminoplasty. And after laminoplasty, good exposure of the dura above and below the tumor. We can see in video, we start to open the dura under high magnification. And this is an important step to avoid injury to arachnoid, as well as some veins and arteries over the cord and roots. As you see here, this is the arachnoid.
Oh.
This is some of the blood vessels over the conus and area of coda equina. We take some take-up sutures to stop bleeding from epidural spaces. You can see here, under high magnification, we can see the arachnoid glands.
Yes. What happened?
Okay, it's not seem to be moving. I guess the screen may be frozen. Hello? Well, I guess they dropped off.
It's good.
Okay, okay, well, we got you.
Okay, okay, again.
Yeah, you're not sharing the screen now. You need to you need to share the video. You fell off the screen share.
Okay, it's play. Sharing?
Yeah, I can't see you're not sharing it. You have to share the screen.
Share it. Okay.
Good day, Chinitz.
Okay, we will share it, please. Wait.
There you go. You're starting it. There you go. Okay, you're going to play the video. Okay. Yep. The video is not playing.
I think we are not online.
I don't know what I did, but I. Whoop, you're frozen now.
Sharing or not?
Yeah, yeah, the video is not playing.
Okay, you see the video?
We can see it, but it's frozen.
Frozen.
Yeah, frozen, yeah.
Okay, it's playing.
Put play, maybe put play because you didn't play the video. Yes, now it is, I think it is okay.
It's playing right now?
Yes.
Not because it'll, okay, it's, yeah, okay, it's moving,
Okay.
yeah.
Okay, right now we start to make arachnoid dissection between
Yes.
root and the tumor. We try to be in arachnoid glands and not traverse this arachnoid glands to the tumor. As you see here, we only cutting the arachnoid between rootlets and the tumor, using sharp dissection and blunt dissection using blunt hooks. We try to define the upper border and lateral border of the tumor. You can see we are doing extracapsular dissection of the tumor between the roots and the tumor. We're trying to reach to the upper wall of the tumor. You see the roots?
Yes.
You see that?
Yes.
Yes, yes.
Okay. This is specious material contained here. So it's it's a pathological sign of dermoid cyst because it contains hair and specious material. I think if it is epidermoid, it will contain only specious material, no hair. But also the cyst contain hair, so it may present all content of skin. You see the hair? Everybody saw the hair?
Yes.
Yes.
Okay. This specious material, once it ruptured intraoperative, you should give the patient corticosteroids to avoid chemical meningitis, like in CB angle tumors, especially dermoid and epidermoids. Here the cyst had been deflated, and we start to make arachnoid dissection between the tumor and different roots. We're trying to dissect the tumor from its lower border.
Wow.
Yes.
It's an excellent picture.
Yes. Everybody can see the hair.
Yes, very good
Yeah,
picture.
but, you have infiltration of.
Yes, we dissect.
No.
Our
Okay.
dissection is between the tumor and arachnoid.
Yes.
Small rootlets.
Yeah.
So you should be always between the tumor and arachnoid of roots to avoid injury to roots or conus. It's all about good and technical microscopic dissection of tumor. Here, this is the part attached to the conus. We coagulate it and we cut it using sharp scissors. And this is the tumor capsule. We will separate the tumor from its lower aspect. We make a small amount of laminectomy to increase the exposure. And we open the dura again to see the lowest aspect of the tumor. Yes, as everybody can see, this is the lower ball of the tumor, and it's attached to some rootlets, but with meticulous, we can yes. Also, we saw the phylum vessel here, but we didn't make the phylum analysis. This is the final view after total resection of the tumor. This is a small amount of a tumor that remain attached to the conus. This is the conus. You see the conus?
Yes, yes.
This is the conus. And this is the last piece of the capsule of the tumor, and it will resected. Yes, everyone can see how beautiful is the roots.
Yes.
Roots.
Yes, beautiful anatomy.
This is the arachnoid. You see the arachnoid. We didn't traverse the arachnoid. We preserve the arachnoid plans, so we can suture it to avoid CSF leak after closure of the arachnoid and the dura using 6-0 or 9-0.
Nice.
Proline. Yes. There's some beautiful tricks I learned from Dr. Ibe about how to suture the arachnoid. You just bring the bipolar and make thickening of the arachnoid before starting taking suture. If you taking suture in arachnoid without making this bipolaring, it will cut through and will not be good suture.
Come again. What do you do with the? How do you make it thick?
The edges of the arachnoid is friable.
Yes. You bipolar.
Yes. If you bipolaring them, it become more thicker.
I see.
It can hold the stretches more easily.
Yes.
And
okay. Okay.
You can see how we are suturing the arachnoid here.
That's very nice.
Yes, everybody must know that arachnoid will
you just do a simple suture. You don't do
continuous.
Continuous
yeah.
suture.
Okay. Nice.
Everybody should know that arachnoid will heal after 24 hours, but it's better to keep it close to each other to avoid CSF leak post-operative.
Nice. Okay. Okay. Good.
So the bipolaring is after you open the arachnoid, not before.
Yes, after not after after we finished the tumor.
Oh, okay. That's when you bipolar.
Yes, after we make bipolaring of the arachnoid edges. You see that part? This
yes,
is
yes.
How it's bipolar. Two, yeah. allow holding of suture.
I see.
You will not make by bothering of it. It will be very difficult to hold suture.
Yeah.
Exactly. Okay.
Nice trick. Thank you.
Yeah, this is a trick of masters.
Nice.
This is after closure of arachnoid, and we will start the closure of the dura.
Okay.
Yes, we close the dura using Vicryl 3.0.
Nice. That's the same thing. Okay.
We usually use Prolene 4.0 or 5.0.
Yes. Borolene, Vicryl, some people use silk.
Yeah.
We in my department we use
as possible.
Nice. Okay.
And this picture is not included in video. We bought the the part that we resected of lamina again and fixed it using many blades. And post-operative patient neurological status was the same as pre-operative, and his bilateral lower limb movements were intact. Thank you, everybody.
Did you use any Durasil on top of the closed dura before you put the laminoplasty back?
What again?
Do you use any Durasil or any glue on top of the dura?
Just the closure of arachnoid and the closure of the dura and putting the lamina back.
Okay.
All these steps will decrease the dead space. The dead space after surgery. If you decrease the dead space after surgery, the chances of leak post-operative is very low. If you make laminectomy and laminectomy without laminoplasty, and you didn't close the arachnoid and making not very good closure of the dura, so the chances of post-operative will be higher.
Do you have any videos of how the laminoplasty was done and how it was fixed back? Do you use a drill or Kerrison punch when you cut in the laminectomy?
We usually making drilling, thinning of the lamina, the facet, medial part of facet, and medial and the lateral part of the spinolaminar junction, and then using plate of the drill. The drill was Midas until we complete it like when you opening the skull like that.
Yeah.
Yes, like we opening the skull and we.
Oh, you use the craniotome to open the lamina.
Yes.
Ah, nice. Okay.
Yes. And after we finish that, we put small mini blades that you use for fixing also that we use for fixing cranial bones. Put it back and fix it.
I mean, I have I want to know when you perform laminotomy with drill. Me usually when I do that, I didn't cut all the bone. I let one attach maybe sometimes in front of. I didn't cut all the laminotomy. I do that, but one extremity I let that in attach. And I fixed that like that. When I finish to close the dura, I just put that back slowly and fixed the bottom, the extremity on bottom and lateral, and after laterally and after one point between the fixation. When you do that, you cut all the laminotomy and to put that on the decks. How you do that?
As I said before, after we making laminotomy, we fix it using mini blades.
Okay.
Mini blades. Okay. This is about 4 millimeter in length and about half millimeter in diameter, and it's very safe because it's only 4 millimeter and it's cortical screw and it's good for fixing lamina.
Okay.
Please next time get a video from Professor Ipe.
Yes.
On how to do the laminoplasty.
Okay.
Yes, right. Nowadays in Africa, it is very difficult to find the blade, all that. So we do that with Vicryl. Okay, nice. Thank you.
If you are in Africa, you know titanium mesh?
Yeah.
Yes, titanium mesh, yes.
You can use a big scissor to cut it like mini blades and fix it.
Ah, yes.
Okay,
Good idea. Good trick.
Nice. Okay, understand.
Tricks of the trade.
Okay.
Yeah, and you don't put any glue on top of the Dura. That is categorical for you. You don't need to put a Dura seal or something on top of the Dura after you suture it.
We didn't used to do that in Egypt, and then here in that case, I didn't see Dr. Aib putting Dura seal or Dura agents post closure.
Hello, Khalif. How are you doing?
I'm good, Dr.
Okay,
Nero.
nice. I think about the glue, I think sometimes we put that when we have maybe brush. I don't know how can I say that, a fistula.
No, when there is a leakage, we always make sure that it's sealed before we leave.
Leakage of Dura. Sometimes when
but
you
then,
close that,
yeah.
sometimes you can put little glue to be sure that you will not have CSF leakage.
But when you are closing, you've taken out all the CSF. There's usually no pressure, so you're never sure whether you're going to have a leak or not. So it takes a while for the CSF to build up.
Exactly. Yes.
Yeah.
Yes.
So what we do
Sometimes
is we usually put Dura seal on top of the closed Dura before, and of course we don't do laminoplasty, unfortunately. But I think it's something that we should start doing.
Yes.
To reduce the dead space.
Sometimes we do that always in the children, and sometimes also young patient on top of 30 or 35 years old.
Okay.
Okay, I'd like to add another trick in how to prevent CSF leak post-operative. Everybody know how to put muscle patch?
Yes.
Yeah.
Sometimes we do that. Yes, we put on top of the suture after you suture, you suture the Dura. You can put that on top. Yes.
Mm-hmm. Okay, but there is two tricks in muscle patch. The first trick is to grind it to release protein. This protein is like fibrin glue. It will attack thrombin and myosin. It will be like an adhesive dural patch. Everybody know
okay.
Yes, this protein is very sticky. If you put over the dura, it be very adherent to the dura. The other trick is to warp it with Surgicel.
Okay.
If you warp it with Surgicel, it will be like a handmade dural patch. Yes, it will like a handmade dural patch, and you shouldn't buy another dural patch after that.
Okay, it's useful. Yes. Okay.
Save the patient maybe $100.
Okay, good. Thank you.
Thank you,
Hi,
everybody.
I hope you are doing well and Happy New Year. I am in tour and they talk to me about you, a lot of good things.
Yeah. Thank you, brother.
I am talking to Hyperion. I say I am in tour now, and they talk to me about him a lot of things.
Where are you now?
Tour, France. Tour. With Christophe Destrieux and Patrick François and Stéphane Velut. They talk to me about you a little bit.
I have come there to teach.
Yes.
Many times to teach.
Okay, nice.
my best regards to Christophe and Igor. Igor is also there. So my best regards.
Yes, I didn't see you, but I am working in laboratory little bit with Christophe Destrieux, and he talked to me about you. Yeah.
There is another chap from West Africa there. Please come here. I think he's from a country in Morocco.
Mauritania. You talk about Ahmed Kleib, yes, but he going back to Mauritania now.
I see. My regards to him also.
Okay, nice. Thank you.
Okay, very good. I guess we can wrap this up, Ipe, and go on to Chingiz, correct?
Yes.
Okay, let's wrap this up, and thank you very much.
Thank you.
Okay, I'm just going to edit that out, and before we start with Chingiz. Hey, welcome, Chingiz.
Hello, everybody.
Okay, well, I'll introduce you. We'll introduce you to everybody. Okay, Chingiz. But let's start this. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good day. This is Dr. John Bennett from Miami Beach, home of Neurosurgical TV. We have the pleasure of having Chingiz Shaskin. He's a neurosurgeon, the head of the ACNS in Kazakhstan, Asia. He's going to give a presentation on how to improve DBS therapy. Before we turn it over to Chingiz, let's go through the panel to meet everybody. Hello, Ipe.
Hello.
Hi, John, and hey, Chingiz, brother.
Hi, Ipe.
Hello, Dr. Jenkins.
Hello, Mohammed.
Very good.
Hello.
Hello, Nuru, could you please introduce yourself?
Okay, I am Nuruddin Bankole. I am come from Benin, but I am in WFNS Rabat Center training of young neurosurgery in Africa. And currently I am in internship at Tour Department of Neurosurgery and also associate research in Laboratory of Anatomy. And nice to meet you all.
Very good, Nuru.
Nice to meet you.
Okay, Abdullah, please introduce yourself.
Hello, everybody. Hello, everybody. Happy Sunday. I'm Abdullah Jimo. I'm a neurosurgeon practicing in Nigeria. I'm currently in Rabat, Hôpital de Spécialité, doing fellowship in stereotaxy, gamma knife, and internal neurosurgery.
Very good. Welcome, Abdullah. Abdurrahim, if I got that correctly, did I say that correctly? Perhaps not. Let's go to Ibrahim. Could you please introduce yourself?
Hello, Dr. Chingiz. Hello, everyone. I'm Ibrahim, medical student and PhD student from Berlin, Germany.
Welcome, Ibrahim. Khalif.
Welcome.
Hello, I'm Khalif, neurosurgery fellow from Kenya, currently in Valencia, Spain.
Welcome, Khalif. And Waleska Sousa, could you please introduce yourself? Perhaps she stepped away. Okay, Chingiz, welcome, and it's all yours.
Okay, thank you very much, gentlemen. Let me share my experience in deep brain stimulation therapy, and I want to deliver my presentation how to improve DBS therapy.
Can you say a few words about yourself, Chingiz, where you're at, etc.?
Okay. I will tell. I'm from. Sorry. I'm from Kazakhstan. This is a large country which is located in Central Asia, and our country is located between Russia and China, and we have borders with the other Central Asian countries. We have a big Caspian Sea, we have a lot of lakes, rivers, etc. So, and we have different landscapes in our country, very interesting place, attractive place for tourism. We have our space program. We have the special place, Baikonur, where the first space shuttle went up in 1961. And our capital is Nur-Sultan, former Astana city, is capital of Kazakhstan. This is a new city, but I live in Almaty city. This is old former capital of Kazakhstan, and I live in Almaty city. It's located near the mountains, and we have very nice cuisine, very nice nature. And I'm neurosurgeon, functional neurosurgeon. I work in private sector now, in private hospital, and I do mostly functional movement disorders surgery, then pain, spasticity, and epilepsy. And let me tell several words about our DBS program. It started in 2013 in National Center for Neurosurgery, and now we have experienced more than 200 cases. We have the movement disorder centers into big cities for patient selection, and I'm a head of Movement Disorder Society Eurasia. This is the special non-profit organization, which is the main organization to distribute and share the knowledge in movement disorders in Kazakhstan and Central Asia. And we usually arrange conferences, workshops at other educational activities in Kazakhstan and other countries. And now we are waiting. I'm invite you to take a part in the second international conference on movement disorders and Parkinson disease, which will be in Almaty City, 27th of August this year. And also we do research activity in movement disorders field. And now we have research in neurogenetics and epidemiology of Parkinson disease in Kazakhstan. We use in our practice we use electrostereotactic system. We call it calls G-frame, and we used Surgiplan and MRI 1.5 Tesla and 3 Tesla. So deep brain stimulation steps usually include the stereotactic frame fixation, MRI with stereotactic frame, when we get these pictures, and then we do targeting using this special software. And we usually use standard targets for deep brain stimulation. This subthalamic nucleus. Subthalamic nucleus is most useful target for Parkinson disease. And we use GPI, internal segment of globus pallidus, which is more frequently used for the dystonia and sometimes Parkinson, but mostly for dystonia patients. And the VIM, ventral thalamus, we use usually only to treat tremor. So we usually use these 3 targets, and mostly this 60-90%, this is STN. So we usually do 2 burr holes in incision and burr holes in the skull. We used microelectrode recording. It's very important to define the target correctly, and test stimulation during the surgery. So while the patient usually awake, and we perform local anesthesia with bupivacaine, and it's very nice, suitable for patients. But anyway, we should prepare our patients for the surgery, so psychologically, and explain all steps of the surgery to be sure that patient will be comfortable in the OR. So after electrode leads implantation, also we use X-ray confirm. This is we usually use CR. And after implantation of electrodes, we usually the same day we perform IPG implantation under general anesthesia. So our experience more to 200 implantations. It was the Parkinson disease, less dystonia, tremor, pain. Even we had the case with Gilles-de-Tourette syndrome. And we have the good results in 75%, reducing motor dysfunctions, improvement quality of life, and better caring for the severe patients. The way to improve outcomes, we divide to the 3 ways. This is pre-surgical, surgical, and post-surgical. Pre-surgical issues, this is the selection. This is the main part of the very nice outcomes is the right patient selection. And the main partner is neurologist. We usually have very good communications with neurologists, and this neurologist should be trained in movement disorders very carefully, and he can be not very old, but young neurologist with a very big impact in movement disorders. Movement disorder centers, this is the multidisciplinary team. We usually have in our teams the neurologists, psychologists, psychiatrists, speech therapists, neurophysiologists, and radiologists, and other nurses who do a lot of stuff with us. And what we need the right diagnosis. For that, we usually do dopamine test. We should realize that drug treatment was failed, or these drugs are so the quantity of the drugs is very high, and we have these problems with the side effects of treatment, drugs treatment. Then we need the clear MRI. So 1.5 and 3 Tesla MRI is very crucial to find the targets, and first of all, of course, to avoid this some organic or problems in the brain. Then we should psychological readiness of the patients for the surgery, because the surgery is should be done for patients who are not in depression and psychiatric diseases, and we don't need any somatic failures in heart, lungs, and infections. And it's very important to that these patients should come to you, to the neurosurgeons, and tell that nothing to treat anymore, and do the surgery for me. So I want to show you some cases. This is the very nice cases in our practice. This is the Parkinson disease. You see this patient, this man in off state when he didn't take his drugs. So he is very his movement are very problematic. He has this after the taking of the drugs, he has these dyskinesias. This is very problematic issues for the neurology, because after the high quantity of the drugs, levodopa therapy, they usually have these such problems in their movements. So this is chorea, and chorea is very problematic for them. So this is very good patient for deep brain stimulation, and we performed this DBS for this man, and we achieved not bad, very good outcome in 3 months after surgery. You see the he doesn't have any tremor. His movement are much more better. But later he improved his movement status, and 1 year after surgery, you see this patient is very nice. He could walk. He can enjoy life, so he can move very fast, and it's very important for them, and the quality of life was very became very high in this case. See this walking is very good. Walking, you see the walking is very nice. So, and because deep brain stimulation is usually works 24/7, so we don't have any problems with fluctuations, etc. This is another patient with implanted deep brain stimulation. You see, the patient can manage the IPG. He has a special remote controller, and for example, now I ask him to switch off the stimulator, this IPG, and you see the symptoms of the Parkinson disease went back. So came back, and you can switch on again. So this video shows us a very nice, very good improvement in the movements in Parkinson disease. You see he has switched on IPG, and now he's better, much more better. This is another case with primary dystonia. Primary dystonia is very severe disease, which usually affect these young people. And you see this young lady with the segmental dystonia, which is going to enlarge to the generalized dystonia, and this is good candidate for the deep brain stimulation. And now the 1 month later, so this young lady is much more better. So, and essential tremor is very severe disease. It looks like Parkinson's disease, but it's not Parkinson's disease. This is severe essential tremor. So this is essential tremor is usually could be treated with drugs, but sometimes the drugs cannot help us because of severe tremor. So you see this guy, they cannot ride this spiral. He can't manage with the glasses. He cannot eat even because, and after the deep brain stimulation, we see the very nice outcome. He can do these things which was not very good, and so this is the. So I have shown the three cases to be understandable how to improve their lives in using the deep brain stimulation. And next we are talking about the surgical issues to avoid complications. We usually divide the surgical complications, hardware-related complications, stimulation-related complications. The surgical is usually thromboembolism. We had this couple of cases with thromboembolism, hemorrhage, infarction, and lead misplacement. Hardware related it's usually because this is the because of these leads are made from the different tissue. This it can be infected and erosion, and the electrodes and connection could be broken, and technical failures could exist. And the stimulation related and neurological failure. Sometimes when we program and stimulate patients, we can achieve diplopia, dyskinesia, dysarthria, paresthesia, and muscle contraction. It could be treated with the changing of programming. Unfortunately, we can achieve eyelid apraxia and weight gain and psychiatric disturbances. We had couple cases with thromboembolism. Unfortunately, one woman died. So after the changing of policy of the prophylactic of thromboembolism, we didn't have any deaths after thromboembolism. And when we thought about why we had these cases, we decided it was both was a quick surgery decision. So the next day surgery, we didn't assess very well the health of the patient, and we didn't do thromboprophylaxis. After the changing of policy, we achieved very good outcomes. And so never push forward and assess the patients carefully. Intracranial hemorrhage, this is a problem because the stereotactic procedures are usually blind surgery. We don't have any possibilities to control the. Only when we planning our targets, we can reveal these big blood vessels in trajectory of the lead. And we had 3 cases. One was unforgivable and unforgettable, and non-symptomatic, 2 cases non-symptomatic. This is case when we put the electrodes in very nice target, but we unfortunately during the surgery we revealed this hemorrhage. Then we stopped our surgery and performed the craniectomy and saved her life. But unfortunately we had this problem with hemiparesis. But this woman came back because the Parkinson's disease is still hurting her. So she decided to do another side surgery. So we did it, and now she's much more better with this brain. So usually we recommend check up blood coagulation, check females for their periods because this lady was in the period. So to avoid blood vessels, we use MRI T1 contrast scans. And during the surgery, we usually chat to patient to check conscience during the procedure. And we don't use 5-channel MER because it's evident that it's much more risk of bleeding. So we use single-channel MER, micro recording. And if unfortunately we have the bleeding from the cannula, we should leave it to evacuate hemorrhage as long as possible. And usually we do CT scans after procedure in 24 hours just to check this probable hemorrhage. In 2 cases, we reveal this non-symptomatic hemorrhage after any problems. The next very high rate is infection. We saw several types of infection. So, and most cases, 90% of these cases, we should remove this device, and it's real fail because the patients usually feel the very nice outcome after implantation, but we should remove it in some time, and they become back in the Parkinson's. So sometimes we can have the erosion. This is the angle of the IPG. This is the connection of the wires, so the connection point of the wires. So they are a little bit bigger than the other stuff, then why the skin could be roast. So we recommend to perform the surgeries in strong aseptic conditions. So we usually perform this surgery in early morning, the first surgery. We use antibiotics, of course, and check the wounds carefully after the surgery, and infection spots sanitation before implantation. Sometimes we could see the connection fail. It's very rare, but might be avoided by doctor and patient as well. We should have good relation with our neurologist who follow up our patients, and he can reveal it in programmer. For example, here we can see the high impedance. So it says us that something wrong with the connections. Then we usually use the X-ray. It's easy to just to reveal these wires, and we see this sometimes this wire is broken. And so what we should do, we should remove and change this electrode. So if there are troubles with impedance, think about connections wires. Check neurological status carefully and use X-rays to detect. And sometimes we can misplace our leads. It happens because a surgeon could have a mistake, and sometimes we can do misplacement, but we can change our next step. We can change our targets and remove these leads and put them again without any problems for the health. So, but anyway, we should be very careful targeting using indirect and direct techniques. Coordinates should be double checked. We usually perform double check by two surgeons. If patient doesn't have any benefits from stimulation, or have side effects, we should check electrode position. So we usually use MRI and replace the leads as soon as possible. End of simulation, EOS. This is a very big problem because we cannot know when the battery will be empty. So we should check our patients for the battery because it can make the sudden end of stimulation could cause malignant neuroleptic syndrome, which the percent of deaths are very high, up to 60%. So this is a severe complication of terminated stimulation. We had 2 cases, fortunately 1 death, and very high rate of mortality. So we should check battery every year. And since 4th year, for example, for Medtronic Activa PC IPGs, we should check it every month. And we can to teach our patients to check themselves, and usually have the 1 extra IPG in our stock to perform the emergency changing of battery. So think about end of service that might appear abruptly, and for this monitor. And final recommendation for all surgeons: fight for patients and don't give up, because our patients usually fills up us and believe us. Thank you very much for this, my intention for my presentation, and I can give my answers for your questions.
Thank you, Dr. Shashkin. That was a great look at Kazakhstan as an introduction and a great presentation. So let's turn it over to the panelists to have comments or any questions. Abraham, do you have any comments or questions for Dr. Shashkin?
Thank you, Dr. Jingis. Beautiful presentation. I wanted to ask how far has DBS progressed for psychiatric indications? You've mentioned Tourette syndrome, I think. How does that go?
Yeah, thank you very much for your question. So psychiatric indication for deep brain stimulation is very, very interesting for me and for other functional neurosurgeons. And I have this experience in Tourette syndrome with very nice outcome, but we usually still use these drugs, medications, but it's no problem because usually they very good tolerated with medication, and additionally, when we use this deep brain stimulation for anterior GPI, it's very nice for the outcomes. And now we have the new data that it could be deep brain stimulation could be used for schizophrenia treatment, OCD, depression. So it's very nice, very useful. Deep brain stimulation is very useful for psychiatric disorders, and you know that the number of indications is increasing every year, and now we think about the very good, for example, Chinese guys, they have oh sorry, they have very nice experience in addiction treatment also as well.
Thank you, because I feel this is always an ethical topic, right? There's probably regulations and everything that keep the field from accelerating maybe a bit faster.
Absolutely right.
Okay, any more comments or questions? Here, let me get you off the screen share there, Dr. Shashkin, so that we can see you full. Okay. Okay, very good. Any comments or questions, Abdullah in Nigeria?
Yes, thank you so much, Dr. Shashkin. I believe this presentation is basically for me before the benefit of others, because I'm actually currently in Rabat for fellowship on stereotaxy, gamma knife and functional neurosurgery. Actually, I followed you in details, all you've talked about, because that is what I'm here for. I've actually benefited a lot in getting a recap of what the whole thing is all about, and it was very exhaustive. Thank you so greatly. It was a very important presentation for me. Thank you.
Yeah.
Thank you, Abdullah. Khalif, anything to add or ask Dr. Shashkin? Oh, Khalif, I think we lost you there.
Hey, Chinggis.
Hi. Yeah.
Chinggis, we need to start functional neurosurgery here in Nepal, number one. And number two, we are starting we're starting the Central Asian chapter of Neurosurgical Coach. So
yeah.
In Kazakhstan, in Kyrgyzstan, in Tajikistan, Uzbekistan, these places we're going to start our program, and then we are going to these countries. We are going to be doing dissection classes, live surgeries and things. So Chinggis, you will need to coordinate everything for this.
Yeah.
Very good.
Okay, of course. We need Central Asia needs in very good classes, very good workshops, and of course dissection courses, because nobody before done here these dissectional courses. And you know that we have a lot of neurosurgeons, and they need this educational activity from us here. So let's start it.
Doing this in Tajikistan for the beginning.
Yeah, of course. So end of this year, January, let's meet in Dushanbe and discuss about it, okay?
Yes. Also, in July, I'm coming to Africa, Tanzania primarily. So we are going to have some life surgery in and after that, we hope to have some dissection courses in Africa as well.
Okay, great. Oh, great.
Very good. Other comments or questions? Khalif, do you have any comments or questions? So I keep bothering you, right?
Okay. Thank you very much for attention. Thank you.
Okay, very good. I guess we'll wrap it up for this week. You can hang out after I finish. And so, what are you up to this week, I?
Beg your pardon?
What are you doing this week?
Well, I'm off to Delhi tomorrow, so I'm going to be seeing some instruments. And we are modifying the entire neurosurgical armamentarium. We believe that the neurosurgical instruments are more than 50 years old, and then this needs to be modified. So I'm going to a factory, and we are trying to modify some instruments.
Very good. Okay, thanks everybody for coming. And Chinitz, we'd like to see you more online, and we'll try to arrange the neurosurgical coach and get that going. And let me just quickly show you something here. This is from Kazakhstan. This gentleman presented at a conference in Spain. And he's associate of yours, right, Chinitz?
Yeah, I know him. He's my colleague from Almaty. He works in another hospital, state hospital, and he is very nice in endovascular procedures. And so I have, I'm in touch with him, and no problem. We can.
Yes, we'll get him.
More people, to deliver the presentations here.
Yes, we'll get him involved too. So thanks everybody for coming. Just stay here, and I'm just going to stop recording. Thank you.
Okay, thank you very much. Bye-bye.
Thank you.
Okay, we're off the air now. So we can just network and talk.
I want to greet Dr. Jimo. Jimo Abdullahi, meet you. How are you doing in Rabat?
I'm good, Newton Bakole. How are you doing in it all?
Oh, nice. Everything's okay. Nice to meet you, everyone.
Well, that's great. We have Africa well represented. 3 African and 1 Central Asia. Kenya, Morocco, and Nigeria. And Kazakhstan, Germany, and Nepal.
Nepal, yes.
Yeah. Yeah, I'm going to show that in Mexico. I guess look at the diversity of the
Khalifa, I don't know if you remember. You remember about our last emails after China.
Yeah.
Many of my colleagues, they tell me, do you have any updates about Khalif? I say, I don't have. I think he don't have also. If not,
it's like the early days of TV. You know, the things were falling down, the props were falling down, and the audio and the video are sometimes off. You can't be too strict. You got to kind of go with the flow. You know, there's going to be glitches in technology. You just have to accept it. That just happens. But boys, yeah, this is great getting everyone together from all over the place. It's fantastic.
Thank you so much. Thank you so much, John. You're doing a great job, tirelessly hosting this.
I tell you, it's inspiring. This is the best part of my career. I'm enjoying medicine more than I ever have. So it's certainly on my last lap of life. It's good to have a good lap. The anchor lap.
You are doing it very energetically. Good.
Well, I know it's going well in Africa, and we want to get Central Asia going too. We want to get all you guys learning from each other because you all have something to teach. So that's what we really want to do, and it'll get better as the better we get with technology. Because Wi-Fi is getting stronger and stronger. It's inevitable that we'll have great connections all over the world soon. So that part of the question will be answered. The technology, we'll catch up.
I think you are right, Jimo. It is very great work you do, John, because I remember a few years ago we should travel. We should go to attend a meeting to have a session like that. We should pay a lot of money to have session like that to see the good scale like IP can show us. This session of Kina Coda epidemic cyst operating and also about DBS. We should pay, we should do visa, we should do flight, we should take flight. And but you see in 1 hour we have all that with just our phone. And I think it is nice net job. And thank you all. Thank you, IP Sherian and Kazakhstan Department of Neurosurgery Functional. Thank you.
I think we're going to see more of Central Asia. Hopefully, Chinitz, we'll get your friend involved. And do you know that there's a group of students in Kazakhstan, the neurosurgical addicts? Are you familiar with them? Chinitz, are you familiar with them at all? They're associates of the neurosurgeon that we met there. But anyways, there's groups of students that are crazy about neurosurgery. We just gotta get them together.
It is like our group AFAN. We try every Saturday to make a course and lecture group also. It is like that, I think.
Yeah. Well.
Good.
Yeah. It'll get better. Okay, gentlemen. I'll wrap this up, and it's going to be edited, Chinitz, and I'll send you a copy of that, so you can use it actually as part of your portfolio on your website or whatever. Hopefully you use it, and hopefully the other guys use it too. Right, Abraham?
Thank you very much.
Right.
Yeah.
Okay, gentlemen, thank you very much.
Thank you, everyone. Nice weekend. Nice Sunday. Ciao.
Bye, guys.